So my name is María-Victoria Mateos, and I work as a hematologist and a director of the myeloma unit at the University Hospital of Salamanca in Spain. And I acted as well as a principal investigator of the DREAMM-7 study. DREAMM-7 is a phase 3 clinical study conducted in relapsed refractory myeloma patients after at least one prior line of therapy, in which daratumumab, bortezomib, and dexamethasone was compared head-to-head with Belantamab mafodotin in combination with bortezomib and dexamethasone. 302 patients were one-to-one randomized to receive either DARA-VD 8 cycles followed by daratumumab monotherapy versus Belantamab mafodotin given at a dose of 2.5 milligrams per kilo IV every 3 weeks in combination with bortezomib and dexamethasone 8 cycles followed by Belantamab mafodotin monotherapy. Treatment was planned as continuous therapy until progressive disease or unacceptable tolerability, and the primary endpoint of this study was progression-free survival, and key secondary endpoints included overall survival, durability of the response, MRD, as well as safety profile. Belantamab mafodotin is a BCMA antibody-drug conjugated. This means that this is a monoclonal antibody targeting BCMA, and we know that BCMA is a relatively new target in multiple myeloma expressed on the surface of the vast majority of the plasma cells. Belantamab mafodotin targets BCMA expressed on the surface of the plasma cells, resulting into the release of a monomethylauristatin F, that this is a cytotoxic agent that induced the apoptosis of the plasma cells. But in addition to this mechanism of action, basically based on the release of this cytotoxic agent, Belantamab mafodotin can induce also cell cytotoxicity as well as immunogenic cell death that altogether can contribute to the great efficacy we've observed with Belantamab mafodotin in patients with multiple myeloma. The most important findings of the DREAMM-7 study were based on the primary endpoint, and the progression-free survival was significantly longer for Bela-VD versus Dara-VD, and the median progression-free survival for Dara-VD was 13.4 months, in line with what we expected for Dara-VD in relapsed refractory myeloma patients. When we changed daratumumab by Belantamab mafodotin, the median progression-free survival increased up to 36.6 months, with a hazard ratio of 0.41, indicating that the benefit was statistically but also clinically significant for Bela-VD over Dara-VD. In addition to this significant benefit in progression-free survival, that indeed the hazard ratio of 0.41 was basically sustained across the different subgroup of patients, including patients after 2 or 3 prior lines of therapy, even in patients refractory to lenalidomide or patients with high-risk cytogenetic abnormalities. We have observed also a significant benefit in terms of overall survival. And this is extremely important because the great benefit in PFS translated immediately in a benefit in overall survival. Median overall survival has not been reached in any of the arms, but the hazard ratio for overall survival is 0.5, indicating that the treatment with Bela-VD resulted in a longer overall survival. Based on modeling, it is predicted a median overall survival of 84 months for Bela-VD versus 51 months for Dara-VD. And again, this superiority in terms of overall survival was also maintained across majority of the subgroups in this phase 3 clinical study.